And this afternoon, we are going to be talking a lot about aftercare. And I think one way to frame this is that so far in this conference, we've been talking a lot about safety. And I think we're going to be talking a lot more about effectiveness this afternoon in terms of how do you take ibogaine and administer it as part of a continuum of care and place ibogaine administration in that context so it is most effective. And actually, our first presenter this afternoon is sort of bridging those gaps by talking about a method that I was fortunate enough to work with Pangea Biomedics 2 years ago, Claire and Sarah Wilkins, who unfortunately are not here, and they use low dose but increasing doses of ibogaine to treat substance use disorders. And that is what our first presenter, Dr. Bouso, is going to talk about. He had an article that was published was earlier this year in the Journal of Psychedelic Studies. And I think his presentation is somewhat based on that paper. So I'll let Dr. Bouso take it away. Give him a big willkommen.
Well, thank you very much. Good afternoon. Thank you for coming. And yes, I will explain a case report about a person who was treated using low, repeated, and increasing doses of ibogaine in the detoxification of methadone. I am Jose Carlos Bouso, already I was presented, and I am the scientific director of the ICS Foundation. Well, as all of you know, the costs of addiction to drugs are very high. Only in the US, there are nearly 22 million adults who use prescription opioids, according to a government's report, in which I get very surprised when I saw it, that 37% of the adult population use prescription opioids. And according also to the National Institute on Drug Abuse at the US, every day more than 90 Americans die after overdosing on opioids. Well, the situation is less dramatic in Canada, but also they are start to having this growing problem. And also in the European Union, in the last report of the MCDDA, where they say the use of synthetic opioids is a cause of concern. The role of synthetic opioids and medical drugs also appears to be important in drug deaths in parts of Europe. In fact, 82% of opioids, of fatal overdoses are because of opioid overdoses. No? The case in Spain, that is the country where I live and work, is less dramatic, although opiates, cocaine and hypnosedatives are the main causes of death after an acute drug reaction. In these deaths, methadone was detected in 36% of the deaths in 2014, and in the 20% was detected methadone but no other opioids. The presence of methadone alone is scarce in Spain. Only 1.5% of the deaths in 2014 and 2.1% in combination with benzodiazepines. This means that maybe an important part of methadone users do recreational uses of other substances, and that there is the interaction may be the more probably cause of the deaths. And as you will know, there is no accepted treatment for methadone dependence. In a recent study that was conducted by some colleagues from me in Madrid, they saw a negative relationship between dose and quality of life, psychopathological symptoms, and cognitive performance. Satisfaction with treatment based on doses negotiated together by doctor and patients are very high, regardless of the doses. The established hypothetical causal dependencies among the studied variables, structural equation modeling was performed, and the results reject the need for high dose if not required by the patient, and highlight the benefits of other psychosocial interventions that lead to recovery, despite the chronification that could imply the use of high doses. Whereas high-dose such programs provide better indications of social control, the patient's quality of life must be one of the main indicators of a successful treatment, as in other health problems. In the guidelines for the use of methadone, the dose that are recommended are quite high, above the 80 milligrams. I think that this is very important, that there is this negative relationship between quality of life and high doses. Yet entering into the area regarding the efficacy of ibogaine in the treatment of methadone, we also published this year with my colleagues Rafael Guimaraes and Jaime Hayek from Brazil, a systematic review of the literature. And it was difficult to find in the papers that have been published showing the results of ibogaine in people with opioid dependence. They mixed heroin and methadone, and in the results they didn't separate what were the results for the people that was being treated with methadone of the people who look for detoxification because using heroin. And in the last paper that we reviewed, that was the last one that was published by the group of GLUE, they treat 27 methadone people that was in methadone maintenance programs, but before administering the ibogaine, they switched methadone into morphine. So there is no clear which is, at least in the literature, which is the efficacy of ibogaine, or at least the float doses of ibogaine in the treatment of methadone dependence. So we were thinking in starting a clinical trial in order to see, because in Spain, as in the other areas in Europe and in US, but among all in Europe, there was the epidemic, was in the 70s and the 80s, the epidemic of heroin. Most of heroin users died. If they didn't die because of the heroin, because of an overdose, they start dying because of AIDS, VU or hepatitis and so on. But now the treatments for treating these infection diseases has very good successful. So there is a very long life in people who were addicts in the 70s, and there are thousands of people who is using methadone where their lives is completely normalized, and they don't have problems with drugs and with family or with work, but they just have a iatrogenic methadone dependence. So in order to start to think how to design a clinical trial focused in those populations, we start a pilot study with a person who wanted to be detoxified from methadone using ibogaine. She was 47 years old and was on methadone maintaining treatment for 17 years after being addicted to heroin. She was stabilized at 37 milligrams of methadone. She was taking higher doses some years before. The last dose that he was taking was of 70 milligrams, and then she can go by herself into 37, thank you, milligrams of methadone, but she couldn't keep lowering the dose. And she stayed during many years in that dose, but she didn't want to take methadone anymore, because every time that she wanted to go to a journey, she had to need special recipes for carrying with her the methadone. Everyone who is in a methadone maintenance program know that is quite incommode and uncomfortable, because the person was every day has to take the medicine and so on. No? She was also an occasional user of heroin and amphetamines and a limited use of ethanol, very, very limited. And she was a daily cannabis user. And during the ibogaine treatment, the patient had a stable work and partner, owned her own house, and was without social, familiar, and legal conflicts assessed by the Addiction Severity Index. As a consequence of her former intravenous use of heroin, the patients acquired the hepatitis C virus. Well, we did a very complete analytic, and from over 70 parameters measured in the analytical tests, only 7 were out of the interval of reference, but only slightly and without clinical significance. And the EKG that was performed before the treatment also saw no abnormalities. And we also did a psychiatric examination performed using the mini international neuropsychiatric interview with no results of any psychiatric disorder. Well, the main objective of the treatment was to completely detoxify the patient safely and with as much comfort as possible from methadone. We used to assess the outcomes, the opioid withdrawal scale that was applied once a day, the short opioid withdrawal scale that was used before each ibogaine session and every hour for the first 6 hours, and at 8 and 12 hours after the ibogaine administration. We also administered the brief psychiatric rating scale before each ibogaine session and every hour for the first 6 and at 8 and 12 hours, and also every morning during all the treatment process. We also used the side effects rating scale UKU to assess side effects of ibogaine, and blood pressure and heart rate were monitored every 30 minutes for the first 4 hours, and then every hour for the next 12 hours, and at 18 and 24 hours post-ibogaine. And also, QTC was monitoring continuously. And the patient had psychological support throughout the treatment, and she continued with psychotherapy for 3 months post-treatment to reorient her life. The treatment consisted of low and increasing doses of ibogaine administered in between progressively decreasing methadone doses, and it was a collaboration between the ICER's support services in Barcelona and Pangea Biomedics with Claire Wilkins from Nayarit, Mexico. The dose and timing of dosing were chosen with the intention of finding a new and less risky ibogaine treatment, avoiding the higher dangerous doses. And ibogaine was donated by a private donor from South Africa, that was Anwar Jiwa, and by Phytostan Enterprises. We analyzed the ibogaine, and the purity was of 96.3% of ibogaine hydrochloride. Well, the treatment consisted of alternating low but increasing oral doses of ibogaine with decreasing methadone doses. In total, we administered, or she took 5 doses of ibogaine. With this method, she stopped taking methadone, and only when the withdrawal symptoms become physiologically evident, she took 150 milligrams of ibogaine. 1 hour after ibogaine administration, of withdrawal symptoms disappeared and reappeared 21 hours afterward. Then the patient took half the basal dose of methadone, 80 milligrams, and maintained it that dose every morning for the following 3 days. She then ceased self-administering methadone, and when withdrawal symptoms became physiologically evident, she took 300 milligrams of ibogaine. This process was repeated 3 more times, alternating ibogaine doses, 400, 500, and 600, while reducing methadone doses in half. The time frame that the patient was administering methadone between ibogaine sessions varied between 3 and 7 days, depending on her work obligations. After the last dose of ibogaine, 600 milligrams, the methadone abstinence syndrome ceased and never returned. Here are the figures of how the withdrawal symptoms dropped after each ibogaine dose. With 105 milligrams, she was in a scale from 0 to 10 in 0.9, and in 1 hour, there were any withdrawal symptoms, and at 2 hours go to 0.1 and then drop to 0, and after 5 hours, again the withdrawal symptoms were increasing. When the withdrawal symptoms were increasing, she took the half dose of the dose of methadone, as I explained before, and we wait for 3-4 days, and then administered the following ibogaine dose that was 300 milligrams, and this time the separation of the withdrawal symptoms were lasting in time, and also with the 400 milligrams and with the dose of 500 milligrams, there were no withdrawal symptoms during 12 hours. The patient successfully eliminated her withdrawals from methadone with ibogaine at last. Each administration of ibogaine attenuated or even eliminated the withdrawal symptoms for many hours and reduced the tolerance to methadone until all signs of withdrawal symptoms disappeared. The lower ibogaine doses taken by the patients were apparently devoid of visual effects, just repressed memories and emotions did surface. There were no psychiatric effects according to the BPRAs, and there were few side effects. The more important side effects that she was not able to sleep at night in the days of the ibogaine sessions. So, in order to counteract the insomnia, the patient took 2 milligrams of diazepam after the first ibogaine session. But since in Spain we have cannabis social clubs, and the subject was a member of cannabis social clubs, she acquired cannabis oil, and she used cannabis oil at night in order to be able to sleep. And after recovering from the last ibogaine session, she did not continue using methadone, benzodiazepines, nor cannabis oil. Regarding QTc and BP, there were no clinical significant decrements. The hair rate dropped with the 400 and 500 milligram doses from 85 to 53 beats per minute between the first 2-3 hours. However, sitting or standing up effectively increased her rate. At no point did QTc measures reach clinical significant scores. The ibogaine sessions appeared to lack visionary content, even with the high dose. Some months after, she took by herself a dose of 700 milligrams of ibogaine, and again, she did not have any visual content. And in analytical tests that the patient completed 7 months after the treatment, all the parameter values were within the interval rates, including those that were not prior to the treatment. According to the patient, this analysis was the only one in the last 17 years where all the parameters were within the normal ranges, although the exact HCV viral load was not measured in the analysis. 24 months after the ibogaine treatment, she was no longer an MMT patient and was without any symptoms of post-acute withdrawal syndrome that she never had with this protocol. She was continuing using heroin and amphetamine occasionally, once per month, intranasally, never again injecting, or once every 2 months. She's a music player, so when she had to go to concerts, probably was the time when she used to take more frequently heroin, but in the times where she has not this more stressful way of life, she used a rational use of these drugs, and she had never suffered again from any problem in relation with his occasional use of heroin or amphetamines. But the most important thing is that she was able to completely cease of using methadone and to have a normal life. Well, if you want more information, this is the reference where this case report was published. And after doing this pilot study with this case, I'm going to present you the proposal that in which we are working, a proposal protocol of a clinical trial. It's a pilot study of the preliminary efficacy and safety of ibogaine in the treatment of methadone detoxification that will follow the same methods. The principal investigators are Trevor Russ, that is here with us, and myself. And the main objective of the study is to evaluate the preliminary efficacy and safety of ibogaine for the treatment of methadone detoxification. The secondary objective of the study is to assess satisfaction with the treatment, with the degree of severity of the possible psychopathological symptomatology and the secondary effects profile of the drug. And it is expected that this study will serve to design safe and effective outpatient treatments for methadone detoxification. Well, it's a phase 2 randomized, double-blind, and controlled pilot clinical trial with parallel group design. 20 subjects will be recruited and randomly assigned to each of the 2 proposed groups, 10 subjects per group. Each subject will receive a maximum of 6 total doses of ibogaine divided into 6 administrations, 1 dose per administration. For group 1, each one of the doses will be of 100 milligrams. And for group 2, the dose will progressively increase by 100 milligrams, such that it will begin at the dosage of 100 milligrams and will end with a maximum dose of 600 milligrams. The idea is the same. Every time that they take, when they stop taking methadone and the withdrawal symptoms become apparent, we will administer a dose of ibogaine. Let's see how many times this dose of ibogaine maintain the withdrawal symptoms, and once the withdrawal symptoms become again apparent, to administer the half dose of the methadone that the subjects were using before, and repeating this process during 6 times. The included subjects will receive treatment for a period of 8 weeks maximum and will be followed for 6 months. The main variable for evaluating the efficacy will be the rate of the reduction of the methadone dosage, and secondary variables will be reduction of abstinence symptoms with the classical questionnaires to assess withdrawal. Also, the hospital anxiety and depression scale to assess anxiety and depression, and the StatMed-Q questionnaire. That is a questionnaire designed for assess the treatment satisfactions with medicines. Well, the evaluation of the safety will be with EKG, with blood analysis and urine analysis, and also with psychiatric scales in order to evaluate not only physical security but also psychological security. And there will be a follow-up at 2, 7, and 12 months after the end of the study, where the patients will be contacted again and will also be a drug test evaluation. Well, that's all. Thank you very much for your attention.
Speak loudly. I'll ask here. I'm just wondering, the half-life of methadone is so long. Have you ever tried the protocol without giving the half dose of methadone and just giving another dose of ibogaine rather than alternating between the two? Because I'm having a hard time grasping how the detox is happening if you're still reintroducing methadone with such a long half-life.
Well, in fact, this is the reason why we are altering the doses of methadone with the doses of ibogaine, because of the half-life of methadone is so long. So this is precisely what the play that we want to play, to decrease the doses of methadone, and at the time that you are increasing the doses of ibogaine, and obviously the plasma concentrations of noribogaine, and in order that at the time that you are decreasing the doses of methadone, you are also decreasing the half-life or the time that methadone is inside of the body of the subjects, at the same time that you are increasing the time that noribogaine is in the body of the people. I think that these results were very surprised, because there is a recent paper published by the group of GLUE where they found no effects on withdrawal effects in people that were in methadone maintenance programs and switched to morphine, and low doses of noribogaine were unable to stop the withdrawal symptoms. And also there is a recent paper published by Deborah Maas in rats, where she needed 30 milligrams per kilogram in order to avoid the withdrawal symptoms for rats addicted to opiates. So it's probably that noribogaine is not so effective in order to reduce the withdrawal symptoms, probably because ibogaine acts mainly on mu receptors, and noribogaine acts mainly in kappa receptors, and maybe these two opioid receptors are playing a different role in addiction. So if you have ibogaine in order to occupy the mu receptors, and then you have noribogaine in order to occupy the kappa receptors, in the first time you are probably with ibogaine reducing the withdrawal symptoms, and with noribogaine what you are doing is decreasing tolerance. This is the reason we are doing this kind of combination.
Very exciting research. When I first approached a clinic in Portugal to embark on clinical trials with ibogaine for the detoxification of heroin addicts, the clinician said to me, he said to me, we don't have a heroin problem in Portugal. We got a methadone problem in Portugal. So this is really, really exciting. But what they also told me was, and I have been told the same by certain people in authority, that the methadone clinics are starting to close down. The methadone factories are starting to close down, and people are now being administered Suboxone. So I'd be very interested in talking to you later about maybe running a trial of this nature for Suboxone, because I'm sure there are many parallels, being a long-acting opiate. Have you looked at Suboxone? Thank you.
Before we have 1,000, I think that we have now 70,000 people in maintenance methadone programs, and in jails probably 30,000 people or something like that. I don't know of memory the figures. So, and what we have in Spain and in Europe is people that was addicted in the 70s or in the 80s, and now they are using methadone. But not all of them, but lots of them have a very normalized life, like the subject that I presented in my presentation, and that there is with methadone, there is this problem that if you go trying to reduce the dose little by little, for certain people, there is an umbral where they cannot go down, and they can stay during decades with the same dose. That is the reason why we are focused in this population, because we're going also go little by little. Probably in the future, we first want to see what happens with this population, if our protocol works, and also if works to expand the sample, and maybe to expand to other substance. But the problem in Spain is methadone. Now, even the problem is no heroin and is no synthetic opioids like in US or in Canada, because in Spain less than 1% of the people use heroin frequently. And after the epidemic era in the 70s, now the people know that they should not inject heroin, so they smoke heroin or they snort. So in fact, there is not a very big problem of heroin users in Spain, but there is a reality that there are all these older heroin users that now have a iatrogenic addiction to methadone, and there is no a solution for them. But of course, I will be very pleased to talk with you regarding other options. Sorry, I didn't hear.
Thank you.
No, we have just finished the protocol. In fact, this was like a kind of trial in order to see if there were some kind of reaction in order to modify, if we should modify, because what I presented was the last version, and if everything is okay and nobody says you are doing something very wrong, we will go ahead to the ethics committee, and our expectation is to start next year in January, February, dependent. I think that we will not have problems with this committee, but the Ministry of Health in Spain is very bit conservative, and I think that but maybe Catalonia will not Spain next year also. So.
Would you mind if I ask who sponsors the trials?
Well, we have nothing close. So for the moment, I cannot give any answer, because we have talked with several donors and several philanthropists, but there is nothing close for the moment. So I prefer to not commit any risk. That's all. Maybe between 150 million euros and 2,000. 2,000. 150,000 and 2,000. 200,000. Yeah. Yeah. Well, thank you.